talk about some more chest trauma here. So just a general approach to trauma of the chest. We specifically are considering the airway and breathing. This is our major concern really in any patient, but when you're thinking about the chest, even more so because your airway goes into your chest and you need your chest for breathing. So more so than a perhaps trauma to the foot, when you have trauma to the chest, we're very concerned about airway and breathing. All patients who have trauma to the chest should be put on 100% oxygen non-rebreather, and the reason for that is because hypoxia is an independent risk factor for mortality in patients with chest injuries, so we want to make sure that we're oxygenating them well. Shock can occur in trauma to the chest, and it can be due to multiple reasons. So you can have blood loss. Now, unlike trauma to the head, where you would die before you'd have enough blood loss to cause shock, with trauma to the chest, you can certainly lose enough blood to go into hypovolemic shock and die. So that's one possible cause. Another is increased intrapleural pressure, and what we're talking about there is a tension pneumothorax, vascular disruption, myocardial dysfunction, pressure on the heart, so thinking there like a cardiac tamponade. So many different things that can cause shock that can originate from trauma to the chest. Chest pain, chest wall pain will result in frequent shallow breaths, so the shallow tachypnea, and less deep breaths means a higher risk for atelectasis and pneumonia, because if you're not aerating, you're not ventilating your entire lungs, parts of your lungs will collapse, and those parts of the lung that collapse are going to be at risk for developing pneumonia. And that infection can be really problematic in certain patient populations, like the immunocompromised and the elderly. So it's very, very important whenever you have a patient with rib fractures in particular, where it may be painful for them to take good deep breaths in and out, that you're controlling their pain so that the atelectasis doesn't happen. So I divided this into two sections. We're going to talk about the cardiac diaphragmatic injuries here, as well as a couple of complications. So cardiac tamponade is an accumulation of blood in the pericardial space, which results in the heart's pumping ability to diminish, and it also diminishes cardiac output. So you have a sac around the heart, and you have blood that accumulates in that sac because of injury, and that's going to place pressure on the heart. And now the heart is trying to pump, it's trying to expand, but it can't because there's pressure on it. You have blood outside the heart that's causing pressure on the heart, and so because of that, because the heart can't expand, it can't put out as much blood into the arterial circulation, and that's going to diminish the blood pressure and cause shock. So this is cardiac tamponade. There's acute and chronic forms of cardiac tamponade. What we're concerned of with trauma is the acute form. The key symptom for cardiac tamponade, apart from the shock, the low blood pressure, is the distended jugular veins, and that's due to right heart congestion because you're getting blood flow into the heart, but not adequate blood flow out of the heart. And because you have that increased pressure in your right heart, you're going to have increased pressure in the proximal veins, so especially veins like the jugular veins. So you'll have distended jugular veins with cardiac tamponade. However, breath sounds will be normal bilaterally on auscultation, and this helps you differentiate it from something else that can look like this, where you have shock and distended jugular veins, and that's tension pneumothorax. So you should have normal breath sounds here. However, when you auscultate, the heart sounds maybe muffled sounding or distant, and that's just because you're listening to heart sounds through a bunch of blood. Another thing that differentiates cardiac tamponade from tension pneumothorax is patients with cardiac tamponade in general are not short of breath. They can breathe. However, patients with tension pneumothorax are in respiratory distress. Other symptoms or findings that you may see with cardiac tamponade are pulsus paradoxus, where you get a 10 millimeter of mercury drop of blood pressure on inspiration, And then on EKG, you can see something that's where you get this pattern where you get a decreased QRS amplitude on every other beat, or just a flat out decreased QRS amplitude in general, and you can see ST changes. So this decreased QRS amplitude is called electrical alternans, and that can be seen in cardiac tamponade, but you can also just get a decreased QRS amplitude overall because of the decreased pumping ability. Okay, so then you get your diagnosis via sonography. That's part of your FAST workup. So remember the focused ultrasound focused sonography for trauma. That's FAST. So that's part of your trauma workup. That helps you, one of the many things helps you rule out is cardiac tamponade. And the treatment is pericardiocentesis. Now, you're either going to do this percutaneously, or if the patient is unstable, then you can do this via an emergent thoracotomy. So it just depends on who the patient is and what the factors surrounding them. So this is electrical alternans. And there's many different things that can give you electrical alternans, not just cardiac tamponade. Notice the alternating QRS amplitudes. A myocardial contusion is similar to a pulmonary contusion, but that it happens in the heart tissue rather than lung parenchyma. So here we have an injury of the cardiac tissue, typically due to blunt trauma to the chest, and there may, but usually isn't, resulting arrhythmias and cardiac arrest. So there may be these complications. In general, there are no specific findings for myocardial contusion, but the natural history, if it does cause symptoms or findings, is that you'll have trauma to the chest, and then after that, you'll develop an arrhythmia or decreased cardiac output, and when you look on EKG, you'll see a new arrhythmia. So with myocardial contusion, the one thing it's very highly associated with is sternal fractures, and that makes perfect sense because the sternum sits right in front of the heart. So sternal fractures are highly associated with myocardial contusion. Another reason that sternal fractures are associated with myocardial contusion is because the sternum, within the chest, the sternum is one of the three most difficult bones to break. The other two being the first ribs and the scapula. So first rib, scapula, and sternum are the three hardest bones to break in the chest. So if you have a broken sternum, you clearly have sustained very high energy impact. For diagnosis, and anytime you have a sternal injury or even just blunt injury to the chest, part of your workup should include an EKG. And on EKG, you may see abnormalities, and you can further investigate this with an echocardiogram. And any arrhythmias or complications are treated as normally. There's no difference in the treatment than if you were to not have a myocardial contusion. Patients with myocardial contusions should be considered for preclinical aortic disruption via chest CT, and that's because anytime you get a strong impact to your chest, you have a risk of rupturing the aorta. Now, remember that about 80% of patients who have a traumatic rupture of the aorta die before they even arrive to the hospital, but a lot of those who don't may have just a small, slow leak, and so they're preclinical. They don't have symptoms yet, but they will go on to have symptoms. So if they've had this blunt trauma that was this severe, you should consider doing a spiral CT for these patients. The right ventricle is the most common part to get myocardial contusions, and that's because it sits anteriorly. Okay, traumatic rupture of the aorta. This is a common cause of death in blunt trauma, typically results from a deceleration injury or just a blunt impact. Location of the injury is most commonly around the origin of the left subclavian artery, and there's a really good reason for that, which I'll show you in a little bit. 80% of traumatic ruptures of the aorta will be dead on arrival. They'll die immediately or shortly after immediately. The other 20% tend to have slower bleeds that may be caught in the hospital. Nevertheless, the prognosis is still poor because these patients are going to require emergent surgery. The symptoms are chest pain, back pain, pseudocoarctation. So remember what coarctation of the aorta is. You see it in little kids, where part of the aorta after the left subclavian artery, all the blood that's going down to the lower extremities, you have a constriction of the aorta, and so you've got higher blood pressure in your upper extremities, lower blood pressure in your lower extremities. And if you have a transection of the aorta, you can have something similar to that. A new murmur, pulse deficits or asymmetry, those are things that you can see in coarctation of the aorta. You can also see that in a mild traumatic rupture of the aorta. For diagnosis, if the patient is stable, the best initial step is to get a spiral CT. The finding that makes you suspicious for traumatic rupture of the aorta is a widened mediastinum, typically in a patient who's already had a chest X-ray, who you're suspicious for traumatic rupture of the aorta, who's had chest trauma, they've already gotten a chest X-ray. However, it is important to remember that the widened mediastinum seen on chest X-ray is usually the sign that is going to be what makes you get the spiral CT, not necessarily these symptoms. So you need to know what a widened mediastinum looks like, in addition to knowing that if you suspect traumatic rupture of the aorta, you should go straight on to a spiral CT. If the patient is unstable and you suspect traumatic rupture of the aorta, then you're just going to send the patient off to the OR for an emergent thoracotomy. The treatment here is surgical repair. You're also going to want to make sure that you pharmacologically manage their blood pressure, as a high blood pressure can exacerbate a tear, and then pain control, because being in pain increases your blood pressure too. So the aorta, all the way up until a little bit after the arch of the aorta to the descending aorta, right around where the left subclavian artery comes off, it's covered in pericardium. So you have tissue surrounding it, and it's fixed to the chest wall. After that, it's mobile. So what you get as a result of this, then, is part of the aorta is in a fixed position, part of it is mobile. And if you have a deceleration injury, part of your aorta is going to move with inertia, the other part is going to stay fixed, and that can cause ripping of the aorta, and that's what causes the traumatic rupture. But it can also be caused due to just blunt impact as well. And so that's also what causes that pseudocoarctation. So when you have coarctation of the aorta, usually that coarctation is right around in the same spot, causes you to have a decreased blood pressure in your lower body, increased blood pressure in your upper body. It's kind of the same thing with the rupture. If you have a rupture, you're going to have slightly lower blood pressure in your lower extremities and a normal blood pressure in your upper extremities. So you can get that pseudocoarctation, as they call it. Here's a widened mediastinum. So if you're suspecting traumatic rupture, spiral CT is the best exam to get initially if the patient is stable. However, if you get a chest X-ray and you see a widened mediastinum, you should instantly be thinking of rupture of the aorta. And part of, just in addition to the fact that you have a wide mediastinum, one of the things you're looking for in a normal chest X-ray is the aortic knob. The aortic knob just is kind of like this little curvature that's right about here. And here's another one. So here's kind of a little bit of an aortic knob, but it's less prominent. So here's another widened mediastinum. Commotio Cordis. This is not something you're going to see in the hospital, just because this is typically sudden death, because it's a severe, you get a severe arrhythmia from a blunt trauma, and you go straight into cardiac arrest, usually ventricular fibrillation, and the patient dies on the spot. So if you get a severe enough trauma to your heart at the right point during your heartbeat cycle, usually right around the T wave, you can go into a cardiac arrest, ventricular fibrillation, and that is almost always deadly. So this is a cause of death, of instant death from blunt trauma to the chest. And most commonly, this is seen in young male athletes, 5 to 18 years old, especially after blows from things like baseballs or hockey pucks. This is almost always deadly. The best initial treatment, since invariably this is going to be in the field, not in the hospital, is CPR and basic cardiac life support, BCLS. I screwed that up again. And then defibrillation, if possible, probably not going to be possible because the most common arrhythmia with Commotio Cordis is ventricular fibrillation. And typically that's not a defibrillable, shockable rhythm. And then, of course, call for help. So this is more something to be aware that it happens. It's not going to come up in the hospital so much. A diaphragmatic rupture is a tearing of the diaphragm, and this can allow abdominal contents into the thoracic cavity, but it doesn't have to. You can have a diaphragmatic rupture and not have abdominal contents in the thoracic cavity until much, much later in life. However, some patients will present with abdominal contents in the thoracic cavity on their initial presentation. So this can be due to direct forces that tear the diaphragm, or it can be due to a sudden severe increase in intra-abdominal or intrathoracic pressure that puts a pressure that tears the diaphragm. Herniation can be absent or missed on initial clinical examination, as I was kind of mentioning, and on chest x-ray. And usually about 50% of patients who have a diaphragmatic rupture don't present until they actually have symptoms. So it's not seen on their initial hospital visit. The symptoms, when it does cause symptoms, are things like bowel complaints. If you have a hernia that's tied off, you can get obstruction, incarceration, perforation, sepsis. Because you have you have bowel in your thoracic cavity, it's going to compress your lungs, so you may have nonspecific respiratory complaints. It can also cause a pneumothorax. For diagnosis, the best diagnostic step is a chest x-ray. It'll be clear as day if you have bowel in your thorax, because you will see the bowel in the chest cavity. I'll show you a picture of it. It's pretty obvious. Usually you'll see dilated loops, multiple dilated loops of small bowel in the chest cavity. It tends to be on the left side because on the right side you have your liver kind of buffering it. You may also see an irregularity of the diaphragmatic border, or if you've placed an NG tube in the patient, you may see the NG tube in the chest cavity. And these are some of the things that may help you diagnose a diaphragmatic rupture before the patient gets any kind of bowel into their chest cavity. Because if you think about it, if the EMT placed an NG tube into the patient before they got to the hospital, they get their chest x-ray, and maybe they have a little bit of bowel in the thorax, you may see that NG tube sitting up in the thorax. So even if they don't have bowel complaints or obstruction or incarceration, you may actually be able to diagnose it right away. But remember, about 50% are not diagnosed on initial exam. The treatment, of course, is going to be surgical reduction, place the bowel back into the abdominal cavity, and then correct the defect on the diaphragm. So here's a diaphragmatic rupture. Here you only see one loop of small bowel in the left hemithorax. Remember, always good to get both lateral and AP views. Here's another one. Here's another one. Here you got multiple dilated loops of small bowel. Okay, an air embolism. So this is not very commonly seen, but it's an important thing to know about. And this is airflow into venous circulation. So remember that your lungs, not only do you have airways, but you also have veins and arteries. And they are usually pretty close together. So if you have injury to a major airway sitting next to a major vein, you can get air that goes straight in to the vein, and that can result in a interference with flow to various tissues. Remember that this isn't exactly like your typical clot embolism or fat embolism, where it moves the same direction as your circulation, goes with the blood. With an air embolism, it goes with gravity. So air is just going to go straight up. So a lot of times this will cause sudden death by causing a embolus to the brain. So the cause behind air embolism is usually penetrating chest trauma. The injury opens up a communication between a relatively high pressure airway and a low pressure pulmonary or other vein, allowing air to enter the venous system. It can also be iatrogenic, so it can be associated with the insertion of a central venous catheter. You can get this from hemodialysis, from thoracocentesis, and so forth. The symptoms a lot of times include focal neurologic symptoms in the absence of a head injury, shortness of breath, cough, acute desaturation, gasping. So this is an important one. If you're placing a central venous catheter and you note that the patient gasps, that's a bad thing. That means that you've probably caused an air embolism by damaging an airway. So keep that in mind. Cardiac arrest can be possible if the air embolism goes to the heart, and sense of impending doom. The air embolism, like I said, does not necessarily follow the path of the venous circulation like a traditional embolism. It moves with gravity. So with patients who have air embolisms, we want to make sure that when we're treating them, that not only are we oxygenating them, but we want to place them in a left lateral decubitus and Trendelenburg position. And what that Trendelenburg position is it means that their head is down and their legs are up. So any bubble, air bubble that's present either stays in their heart or it goes up somewhere else to the legs, not to the brain. As far as diagnosing this, you just keep a high index of suspicion, especially patients with penetrating chest trauma and patients who you've undergone those high-risk procedures like placement of the central venous catheter. The most widely used diagnostic procedure to diagnose an air embolism, if you do need to use a diagnostic procedure, is a transesophageal echocardiogram, and you just look for the air bubble in the right heart. A fat embolism is more of a syndrome than just a plain embolism. So usually this is due to long bone fractures, which includes rib fractures, but especially includes fractures of the femur or the humerus. And the typical patient with a fat embolism is one who has sustained multiple orthopedic trauma, who's developed worsening respiratory distress. So the symptoms include hypoxia, respiratory distress, shortness of breath, adventitious lung sounds, fever, petechiae, and altered mental status. For diagnosis, you get a chest x-ray. What you'll see is bilateral patchy infiltrates, and on your routine labs, you'll see thrombocytopenia. Those two findings in the presence of orthopedic trauma are very, very suggestive of a fat embolism. Unfortunately, though, there's nothing we can do for this. The treatment is just supportive. Generally, it's going to require intubation because of the respiratory distress. So other injuries I wanted to bring up, really just one, is the sternal fracture. I kind of alluded to it earlier. This is just a fraction of the sternum. It's associated with a very high, direct, blunt blow, especially in postmenopausal women or anybody who is at risk for fracture. So we're thinking people with osteoporosis, people with metastasized cancer. Only the first rib and scapula are as hard to break as the sternum. The major immediate concern with sternal fracture is cardiac contusions and decreased ventilation, similar to with rib fractures. You can also get compression on the superior vena cava, so that can cause problems there. For diagnosis, usually a chest CT is preferred to a chest x-ray. It's a little bit harder to see injuries to the sternum on chest x-ray. But if you do get a chest x-ray, you need to get a lateral view because it's almost impossible to see a fracture of the sternum on AP view. So you want to get a lateral view. You always want to get at least 2 views on a chest x-ray, but I'm just pointing out that for when you're looking for a sternal fracture, it's really going to be that lateral view that helps you. You'll also want to obtain an EKG just because we're suspicious for a cardiac contusion. The treatment is pretty much the same as what we do for rib fractures. It's just pain management and pulmonary toilet generally for these patients because there's really no localized injections that we can give them for pain. We're going to need to give them opiates. So it's all the more important that they are using their incentive spirometer. If you have any questions, let me know.